Okay, so thank you very much about this thing. So now I will start with, of course, Dr. Danielle, that the availability of aerosolized this alloprost is how it is. This is available nowadays. Especially, I'm talking about the infants, which is more prone to the bronchiolitis and all those.
Alloprost has no place in bronchiolitis. Bronchiolitis is not ARDS, it's just an airway disease. And usually can be treated just with CPAP very effectively. Everything I told about alloprost is when you have a severe ARDS, so a white lung, you know, with a parenchymal extension of the disease.
So the other thing is that let's say move to the with the ARDS and they have the component of PPHN. Okay, so do you recommend this alloprost aerosolized in that condition also?
Cannot do that because the first line for this is always NO nitric oxide, unless you don't have nitric oxide. Then in that case, it's better use alloprost than anything.
Okay, so the other thing is that you know, for the neonatal RDS, we gave the surfactant. So is there any time for giving the surfactant in the ARDS? The early we gave or the later we gave, or we will see how the baby they're doing?
There's nothing about the timing. That's a very good point. I tend to say that obviously if you give it too late, when you are already in the second phase of ARDS with fibrosis, you cannot expect any miracle. But then it could be very difficult to understand what is the right point to give it.
Yeah, and you show the slide of different surfactant. So for example, like in the newborns, I mean neonates, the poractant alpha is a little bit more efficient, or efficacy is high. But what about the in the ARDS in a bigger kid? If we try to give surfactant, is there any make a difference in to come out of the ventilator?
To understand that, I should have showed like 100 slides of pulmonary biology, and I didn't have time. The only thing I can tell you is that every type of surfactant that is injected into an ARDS lung is going to be somehow deactivated and injured, okay? Now, also poractant alpha, but because of its composition and because of the possibility to inject a higher dose, poractant alpha is gonna stay more and is gonna be less deactivated than the others, even in ARDS. This is known from a biological point of view, has been shown in many, many animal models.
Yeah.
And we should consider. I'm sorry, I have a call from the ICU. Give me a second. Wait.
Maybe we can move on to another question in the meantime.
Yeah, good idea.
Yeah.
To Martin and to Dr. Peter, has sildenafil been used in pediatric ARDS successfully? IV sildenafil?
I'm sorry.
Any studies?
Okay, Daniel is. So what about the steroids? Okay, the use of steroids in ARDS. What do you think? This has a long-term effect on the kids or not? If we give the steroids, and it is again the dose base as like in the BPD.
There are no data about long-term because anyway, there is not so many data about PARDS and steroids, but I tend to say that this is not a problem because anyway, we're not using steroids for such a long time. Okay. And we're talking about so severe patients that we shouldn't worry about that. We should worry first of all of saving the baby.
Sure. And the other thing is that the inhaled steroids versus IV steroids, is any difference, anything?
There is no data at all.
Okay.
There's no data at all telling anything about what should be preferred between the two. But again, since at least we do have some doubts about the actual delivery of nebulized steroids, and we're talking about the more severe patients, I believe that if we give steroids to PARDS kids, we should give them intravenously, exactly like it has been done in adults.
Ah, okay. 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 Yeah, Rajiv, you have some questions?
Yeah. In the neonatal world, sildenafil has worked well intravenously in pulmonary hypertension. But what is the experience in the pediatric intensive side? This is to both Daniel and Martin.
With what? Sorry?
Intravenous sildenafil.
Which drug you're referring to?
Sildenafil.
Sildenafil.
Oh. Well, first of all, in PARDS, there is nothing. There are a little bit of data in neonates, but let me tell you that I do consider this option inferior to the molecules that I showed you for several. Sorry? Can you hear me?
I think.
Yes, doctor.
We can hear you, Daniel.
Yeah, now you...
For several reasons. Intravenous sildenafil is not a good option for several reasons. First of all, because it's intravenous, which means that it's going to reach the lung on its entirety. So you're going to vasodilate areas that are well aerated and also areas that are not well aerated. So you can even have a sort of a paradox increment of shunt fraction, which is not a good idea. Conversely, when you use a pulmonary vasodilator that is direct into the lung, like nitric oxide or alloprost or anyway prostacyclin, this is going to reach only the alveoli that are well ventilated. And so it's improving the ventilator perfusion mismatch. Not to mention the fact that sildenafil, obviously IV, is going to have some systemic effects on mean airway pressure and systemic perfusion, which is something you don't see with alloprost and the local pulmonary vasodilator. So this is why we almost never use it, actually.
Yeah, Rajiv, I have a question regarding this. The IV sildenafil, the efficacy of oral sildenafil, there's a meta-analysis in the newborn with the PPHN is the same. So why you are insisting on IV?
That is because Stenon study, because myself and Patrick McNamara are working on a formula.
Okay.
We do not use nitric oxide in low middle income countries. So
but this is very expensive, you know, IV sildenafil.
Yeah. No, Steenhorn had used one intravenously for 3 hours, and that produced good serum sildenafil levels of 2 nanogram per deciliter over a short period of time, maybe within half to 3 hours. Oral sildenafil takes at least 1 day to reach a critical sildenafil level. So that's the time we prevent rebound pulmonary hypertension and PPH.
Yeah. So, Martin, there is a question about from Dr. Raymond Rahmani that is there any minimal mean airway pressure to use with a certain amplitude to give most efficiency of the ventilation? I mean, the minimal airway pressure actually you want to know.
Well, you have to distinguish for the oxygenation and the ventilation, and a minimal airway pressure. There is no such number. The only thing is that it cannot be lower than the mean airway pressure on conventional ventilation, because I've seen that happen. So if you're on a mean airway pressure on conventional mechanical ventilation, let's say about 15 centimeters of water, your mean airway pressure on high frequency should at least be somewhere to 5 to 8 centimeters higher than what you have on conventional ventilation. Otherwise, because your data volume, your stroke volume envelope is really small, otherwise you will get de-recruitment. And it depends on the lung mechanics. It depends on where you are in the disease trajectory, on which day. So there is no magic number necessary, except for the only thing that it can never be lower than unconventional. I don't know, Peter, if you have any additional thoughts on that.
I think the question was addressed a little bit different. The question was, is there a minimal air vacation in relation to the amplitude you use? And this is an ongoing discussion all the time. It comes from very old times when they used in the early trials very low frequencies, clear that the amplitude because of the pressure swings that are transmitted, might create negative intrapulmonary pressures. Nowadays, where we use high frequencies, we have much less pressure transmission. So the question or the fear that there may be some airway collapse does not exist really anymore. So I never saw in my experience the phenomenon of choking points. So I think it's something you have to forget. Trial in your mean air pressure according to oxygenation needs, dial in your amplitude at the highest frequencies to get your CO2 out.
The other question is a general question, Peter or Martin, anybody can answer that the role or the place of any hypercarbia or permissive hypercarbia in ARDS, in pediatric ARDS, or it is no for the pediatric age group.
Peter, you go first.
Oh, that's yours.
Well, to put it very easy, the role of hypercapnia, if there is no strict contraindication for hypercapnia, let's say the patient with severe traumatic brain injury or the patient with severe pulmonary hypertension, where you want your pH to be within the normal range, then to put a real binary, I don't care about CO2. It's not for, I'm not talking about preemies or whatever, I'm talking about the pediatric patient. So as long as the pH is, and I tend to be a little bit liberal on the pH than some of my colleagues, but as long as the pH is, let's say, above 715, 720, then it's fine. I'm not aware of any studies, but maybe Heidi or Peter know studies that have shown a relationship between high CO2 and adverse neurologic outcome in PARDS patient or any other ventilated kids in later on.
Okay.
There's no data about this. Just to remind you, when we talk about hypercapnia, we talk about permissive hypercapnia, which means you are urged to accept. It's not the treatment concept, which is often misunderstood. And there is no data showing that allowing for high CO2s is improving outcome. It was just combined with the ventilator settings behind that. The major thing for having better outcome was the more protective ventilator setting. So permissive cap is not the therapeutic approach.
Okay. The other question is regarding the overall management of the ARDS. The mostly people are sending the questions that they are related to the infection or the pneumonia, or the COVID. So how aggressively you think that we should treat the infection, and then we also think about how you relate these two together, especially in the young pediatric age group. I'm talking about 1 year, 8 month old.
Well, Heidi, take it away.
So yeah, I think mostly they think that this is pneumonia first and then it happens. So what do you think about that?
So I was on the ICU call for a quick second. So the question between pneumonia and sepsis-induced ARDS, that was in the chat. Yeah,
exactly.
So, you know, I don't think in all of our studies that we've done, we really haven't necessarily seen, we've definitely seen an overlapping in that pathophysiologic basis. And as I showed you in the talk, there definitely are some more elevations of the vascular endothelial injury markers in sepsis patients or indirect ARDS than the primary pneumonic patients. In the end, in terms of severity of disease and outcomes associated with that, you can get to very high levels of all of those markers in both pneumonia and sepsis, and clearly pneumonia is a form of sepsis. So it's a little bit smooth across that. Interestingly enough, when we put in our latent class analysis, the cause of ARDS was not as predictive as the levels of these markers. So we are going to see individuals who are able to be more or less hyperinflamed no matter what severity of ARDS they have and what the cause is. So, so I think there's more to come as so much of this discussion is, but I think it's highly relevant. And to go back to that last question, and I'm unfortunately going to have to jump off this Q&A in a minute, as well. But Brian Kavanagh used to spend an awful lot of his work on permissive hypercapnia and the potential benefits of hypercapnia in terms of NO production in the lung. And he's obviously no longer with us, but that was a whole field of his study, is the impact of permissive hypercapnia, not all of which are negative at all. So,
okay. So thank you very much, Heidi. And I think most of the people has to go now. So Rajiv, you do your concluding remarks.
I will conclude the session. So today we had a very wonderful session. It was almost like a brainstorming session. Almost all the countries have participated in our network, and I think I already mentioned what we talked today would be probably the research results will be out in a decade. But overall, I think this was one of the best composite symposiums on ARDS I've seen. By almost all aspects we have touched, and the questions asked were very meticulous and answered very precisely. And the gray areas were identified, and we know where we are to improve, etc. And a lot of directions are shown in the ventilatory strategy and in the drug therapy, which we are also interested for the next few years. Thank you so much for coming, and we look forward to meeting you in some other network.
Thanks a lot, Rajiv, to arranging all this. And I must thank all the international speakers. And I mean, it's really great. And all the participants, it's more than 680 participants. And there are a lot of other questions. But of course, I am seeing in the chat box, everybody has other commitments. So we will not keep you there. So thanks a lot.